Hi everyone, tonight we have another subspecialty VMR. This time rheumatology will be the focus. And for that we have three incredible guests. We have Josh, Anisha, and Lakshmi. So first, let me introduce Dr. Dua, Anisha Dua. She's an associate professor of medicine and also the program director of rheumatology at Northwestern Medicine. Thank you so much for coming.
Thank you for having me. Nice to meet everyone.
So I would like to ask you a few questions. First, why you chose rheumatology and what do you do for fun outside of medicine?
I chose rheumatology because it's the best field that exists. Honestly, it's super challenging. The more you learn about it, the more interesting it gets. Unlike I think some other specialties, I feel like you get exposed, you build long-term relationships with patients. You kind of really work through all the pieces, and we'll be talking about this case, but you really connect all the dots between the physical exam, the patient history, and use all the clues to try to make diagnoses in a way that I think is keeps you consistently, your mind active, and it just becomes more and more interesting. And yeah, the patients are amazing, the peers are amazing, and it's a great field.
Yeah.
And what do I do for fun? A lot of things. I like to travel, sports, pottery, and I don't know, that kind of stuff. Read books.
Yeah, that sounds amazing. Thank you.
Yeah.
We also have Lakshmi. She's a she's a second-year rheumatologist at Northwestern Medicine. Thanks so much for coming, Lakshmi.
Yeah, no problem, Rafa. It's really nice to be here and see all of you enthusiastic applicants and medical trainees. So I'm a second-year rheumatology fellow at Northwestern University in Chicago. And rheumatology is absolutely the best field. It has the best people. And also I think the feeling that drives me is that every patient I see, I go in with a completely blank slate and I don't know what I'm going to expect. And I just need to integrate so many parts of medicine that every day is a challenge, but it's an awesome challenge. So I really enjoy putting pieces of the puzzle together and long-term bonds with my patients. So that's what drove me to pick the field. And then what I do, any kind of sport, any kind of outdoorsy, like running, yoga, volleyball, cricket, whatever, anything. I love playing and reading books and traveling, I guess.
Oh, incredible. If you had to tell me a place to visit, which place would you tell me to go?
Oh,
one of your favorites.
I love India, but we recently went to Greece and that was really nice. So,
oh, yeah.
Greece,
yeah, Greece is really incredible. And we also have Josh. He's also a rheumatology second year at the Northwestern. Thank you so much for coming, Josh.
Thank you. Agree with everything that Lakshmi and Dr. Dua said. Rheumatology really is the best field. So, I mean, in addition to just the intellectual piece, the patients are amazing. You get to form long-term relationships with them. Especially in the past decade or two, we now have a ton of great treatments, so we can really do a lot for people, which always feels good too. So yeah, it's totally the best. And I can't understand why it's not the most popular field, though it is getting really popular. So I'm happy about that.
Incredible. And what do you do for fun outside of medicine?
Well, I am a diehard Minnesota sports fan, so that takes up some time. And then I also like cooking and baking. I've started baking for my 1-year-old, so it involves lots of sugarless recipes or sneaking sugar into it in different ways.
And what is your favorite thing to cook?
My favorite what?
Thing to cook.
Oh gosh. Oh my gosh. Well, recently it's all different types of muffins for the little one.
I see.
So yeah, I've developed a smattering of fruit style muffins.
Oh my God, that's incredible. I'm sure Lakshmi and Anisha will.
Yeah, you need to bring them into clinic.
Yeah.
Yeah, I mean, I don't. The adult palates I still have to work on, but the babies love my cooking.
We also have incredible CP Overseeing members that will help us in the session. Chiara, please go ahead and introduce yourself, please.
Hi, my name is Chiara. I'm super excited for today. So I'm a CP Silvers team member. I like internal medicine. Internal medicine for me is amazing. And what I like, well, my actual situation, like studying for step 2 CK and working, studying and working. And what I like to do, to play with my dog. He's 2 years old. He's 2 years old, and he is beautiful, amazing. I love him a lot.
Yeah, we know his dog is amazing. He's really, really beautiful and incredible. And we also have Shema. Shema, please go ahead and introduce yourself, please.
I am Shema, and I'm also CP Service team member. And what I like to do outside of medicine, I mean, I've recently become a coffee addict, and I realized that I don't like to buy coffee in a coffee shop because I have the tendency to put too much sugar inside, and I don't like the people looking at me when I put too much sugar inside. Okay, yeah, that's all.
You don't like to feel judged to them. So Shema, you can share the screen and we can start the case whenever you're ready.
Okay, ready? All right, so welcome everyone to today's CPS virtual morning report. The chief complaint for today's patient is a 58-year-old man who presented with a week of joint pain and confusion. The HPI, the patient initially developed left shoulder pain 1 week prior to presentation. This again then spread to his right shoulder, at which point he had significant difficulty in even moving, abducting his right shoulder, and had weakness in his entire right arm. He couldn't reach overhead or lift any items. And subsequently, the joint pain then moved to bilateral wrists, which also became red and swollen. His husband also noticed that the patient was becoming more confused than usual. And also because of his fatigue and weakness, the patient fell down, landed on his right hand, and was brought into the ED for further evaluation. So that's the basic HPI.
It sounds very intriguing. Thank you, Lakshmi. So let's start with Josh then. Josh, what goes into your mind when you hear such HPI?
So I guess the first thing is it seems like he's having migrating joint pain and he's having difficulty moving his shoulder. I think one of the first things I like to differentiate with joint pain is it active or passive? Meaning, you know, is he having difficulty moving the arm due to pain or moving the shoulder joint due to pain? Or is he having pain at rest? So like when I say passive range of motion, would someone else be able to range his arm no problem? That might mean that the etiology is more mechanical, or is he having more, or if he's only having pain with active range of motion. The other thing I want to know, if he's having severe active and passive range of motion of the joint, a rheumatologic emergency we're always concerned about is a septic joint. So if he can barely range the joints at all, that really gets me concerned about a septic arthritis. I think, you know, one of the other things that you mentioned, Lakshmi, is that he fell. So anytime there's trauma, I want to know, was there any abrasions to the skin that could lead to infectious seeding, either local tissue trauma? You know, we've certainly seen trauma leading to local infections or infection seeding the joint. I think you also mentioned that he was more confused than usual. I kind of interested to know, does he have any baseline confusion? And then, you know, any other time someone comes in with joint pain, you know, we want to know if there's any other associated symptoms. So is he having any rashes, any GI symptoms, either now or preceding? Because certain infections, specifically GI or genitourinary infections, can predispose to joint pains down the road. So is he having any diarrhea or abdominal pain, any penile discharge, any dysuria, or any infectious symptoms at all? I think that is what I would want to know to start.
Incredible thoughts, Josh. What about you, Anisha? Anything else you would like to add?
No, I think Josh pointed out some of the salient things we wonder about. You know, he has this migratory sort of polyarthritis, and you want to know sort of how severe it is. It seems sudden in onset. We want to know. Clearly, we'll get into this, but is he febrile? Is there other associated symptoms which are definitely going to help drive our differential? But Josh, because he's a wonderful fellow, has picked up on some of the important things in the history. Has he had prior episodes of joint pain before this, or is this all of a sudden after this traumatic event? I think you did a pretty good job of pulling out the main things.
One question that I would like to ask is, how do you tackle like rheumatology and neurology? Like, what things pops up in your mind and you're like, oh, I can't miss it?
Rheumatology and what? Sorry?
And in neurology, because it seems like there's a neurology flavor in this case, like the weakness and the confusion.
Yeah, I think that's definitely a good question. There's a lot of overlap with rheumatologic diseases and so many subspecialties, which is what partly keeps it exciting. With neurology, I mean, you wonder, right? Of course, if there's an infection, is he just getting confused and delirious from the infection? Or of course, there's definitely a lot of connective tissue diseases and vasculitides that can involve the neurologic system and also involve joint pains. And so you keep your differential pretty broad in somebody that's presenting like this, so we can kind of sort through and tease out what are the other features that are going to push us in one direction or another. But the relationship between peripheral neuropathies or confusion, there's many connective tissue diseases that are associated with that, including, like I said, the vasculitides, lupus. I mean, there's a whole slew of possibilities.
Incredible. Thank you so much.
Mm-hmm.
Lakshmi, could you please carry on?
Yeah, so I think those were great questions, and hopefully we'll get some more clarity as we move on through the case. But to answer your questions, Josh, he had pain with both active and passive range of motion. At least from the initial history, there wasn't any mention of tissue trauma, but we'll get into the exam. And then about the confusion that you asked, that was a good question. So he does have a history of baseline short-term memory deficits related to an aneurysm, which I'll get into in the medical history, but he does have some baseline memory deficits, but he was more confused than usual is what the husband mentioned. No rash, no genitourinary symptoms, no gastrointestinal symptoms preceding his presentation to the ED. But they did mention that even though they hadn't measured his fever, his temperature at home, he was surprised to know that he was febrile when he was at the ED. And I'll get the vitals to you shortly. So now that we've completed the HPI, we can go into the medical history. So he has a history of well-controlled HIV. He's on regular heart therapy. He has type 1 diabetes. He's on insulin. He has a remote history of posterior intracerebral aneurysm, which has been coiled and complicated by the memory deficits, in addition to some chronic comorbidities. Family history, no pertinent family history that he can recall. Social history, he works a desk job. He lives at home with his husband, with whom he's sexually active. No tobacco abuse, no alcohol abuse, no substance abuse. Medications-wise, just his regular heart therapy. He's on aspirin, a statin, and a PPI as well. Moving to the vitals. So his temperature on arrival at the ED was 39 degrees centigrade. His heart rate, 108 beats per minute. Blood pressure, 110/74. Oxygen saturation was normal, 99% on room air. Respiratory rate was 14. Coming into the exam, his general exam, he looked like a pleasant middle-aged male, no acute distress. ENT exam, no facial trauma, no rashes over his face. Cardiovascular exam, SpO2 heard, no murmurs. Pulmonary exam, normal vesicular bed sounds, no crackles, no wheeze. Abdomen was soft and tender. I'd like to mention the musculoskeletal exam next, if that's okay. So his musculoskeletal exam, starting with his wrists and hands, His left wrist was swollen over his flexor pollicis longus tendon and also had some tenderness on palpation. In addition to erythematous change just around the wrist area, just proximal to the wrist. So wrist was erythematous, tender, swollen, and pain along the flexor pollicis longus. In addition to that, he had full range of motion of his wrist and his fingers. His right wrist was swollen, but and tender to palpate, but it wasn't really erythematous. And he was unable to make a fist on the right side. Elbows, there was no synovitis, no swelling. Coming to the shoulder exam, mainly his left shoulder, there was no remarkable features on examination, but his right shoulder, there was frank synovitis on examination with limited active and passive range of motion. And just to the remaining joints, his knees, his ankles, his toes, the small joints of his hands, there was no synovitis or swelling or tenderness. Neuro exam, normal muscle bulk and tone, but he did have 3 out of 5 strength with respect to his elbow flexion and range of motion at his shoulder, so abduction. Remaining neurological exam was within normal limits, and skin exam, Josh, like you had asked, there were no tears, trauma, no recent skin lesions, evaluations.
Oh, that's incredible. Thank you so much, Lakshmi. Anisha, can you start, please?
Yeah, absolutely. So I think, we're talking about many different joints involved. And I think the first thing to do is to think about sort of how to approach just joint pain in general. So some of the ways, that many of you kind of already know, but when you think about joint pain, you want to think about how many joints are involved, right? So is it a monoarthritis, which would just be one joint? Is it an oligoarthritis where you've got like 3 to 4 sort of large joints involved, or is it a polyarticular process, which involves multiple small joints and other joints? And so when you first tease that out, it can help sort of drive a little bit of your differential, right? If you have one monoarthritis, you might be thinking more about like crystal arthritis. When you've got polyarticular disease, things like rheumatoid arthritis or some of our other inflammatory arthritides would come up higher in your differential. So the first thing to do is think about the number of joints involved and what's the distribution of the joints, right? And so then I think the next thing you want to try to tease out from the patient history and the exam is this an inflammatory or non-inflammatory process going on? And there are certain clues that we ask our patients to sort of figure that out. Of course, when you're examining the patient, you feel for warmth, swelling, tenderness, effusions, things like that, and synovitis, which can be difficult to feel and understand at first, but the more joints you touch and press on, you'll start noticing some of those subtleties. So I think with inflammatory versus non-inflammatory, and I always talk like this to my patients too, non-inflammatory processes are basically things that have to do with mechanical issues. So something going on with, wear and tear of the cartilage leading to osteoarthritis. You want to think about periarticular versus articular. So is it something with there is a tendon or ligamentous rupture, something like that that's driving it? Or do they have inflammatory features, which we think about stiffness in the morning, that actually gets better with activity, and that stiffness usually lasts, half an hour to an hour or more. And generally with like mechanical processes or non-inflammatory processes, you're thinking more about like more often people will say they have pain with certain activities, or when they're climbing stairs or when they're trying to exert themselves, they start having more pain. Whereas with inflammatory processes, a lot of times that stiffness is really worse in the morning. So those are just like some of the things you want to think about when you're looking at somebody coming in with joint pains. And in this case, the patient had sort of an additive joint pain, it was sort of progressing from one joint to another over periods of time. So you'd want to know, is it popping up in one place, going away, coming back somewhere else? Or is this sort of like a progressive, incline in his joint issues? And then of course, some of the like associated features that we talked about. But I think once you're thinking about an inflammatory process, and in this person, they've got low grade fevers, and they've got a little bit of tachycardia, they have physical evidence of swelling in their joint exam. And like Josh mentioned, the active and passive range of motion is limited. You are thinking about some sort of inflammatory process. And then once you're in this inflammatory zone, then you're not as worried as much about, a fracture or osteoarthritis or something like that. you're really thinking more about some of the inflammatory arthritides, infectious arthritides, reactive arthritis, and some of the sort of different syndromes that we'll probably talk about more. But I think that's probably a good way to start when you're thinking about somebody with many joints involved in joint pain.
Yeah, incredible summary. Thank you. Josh, anything else you'd like to add?
No, I think, I think Dr. Dua said it all. I think, other clues in the joint workup, when you're thinking there are particular, some of our diseases have particular patterns like RA, if you see someone with classic MCP and PIP disease, there's a handful of conditions that can do that, but there are definitely particular patterns we look for. Or is this kind of persistent disease, or is it migratory? Is it here today but gone tomorrow? I think kind of those flavors are all important to tease out in the history.
Yeah, absolutely. Like Josh was saying, I mean, axial involvement versus peripheral involvement. Is it symmetric? Is it asymmetric? There are buzzwords that we think about, and because that's how patients present, right? So if you've got a symmetric small joint polyarthritis, that sort of gradual in onset, something like rheumatoid arthritis is going to move up in your differential. If you have somebody with a history of psoriasis and some back pain and stiffness in the morning and some hip issues and a large swollen knee, you're going to think more about things like psoriatic arthritis, So exactly what Josh was saying with the pattern of joint involvement, that gives us a lot of clues.
And what if this was like a consult question? What would you like to do for this patient right now? Like what type of exams would you order, imaging, anything?
So, I would start with the basic workup. So, basic labs, CBC, CMP. I think even though his exam is suggestive of an inflammatory arthritis, I'd want to make sure to get inflammatory markers. There are a number of things I'm thinking about already on the differential. I don't know, Lakshmi, do you want to just give me his basic labs first, and then I could kind of tell you what I'm thinking, or do you want me to get into the differential?
I think we can start with some basic labs if that's okay.
Sure.
Just a bread and butter complete blood count and comprehensive metabolic panel. So from the complete blood count, white count was 14.2, hemoglobin was 11.3, platelet counts 216. His electrolytes were grossly normal, but I can go through them if you'd like. Sodium was 130, potassium 4.5, chloride was 95, bicarb was 29. BUN was 28, creatinine was 1.8. This is elevated compared to his baseline. His glucose was 307. Calcium, phos, and MAG were all normal. His liver function studies were normal as well. So his AST, ALT, ALK-phos, bilirubin, albumin were all normal. In addition to this, they did get an ESR, which was 131, and a CRP, which was 228.
So I think, definitely drawn to, elevated white count is nonspecific. In the setting of his fever, though, it definitely makes me start to think about infection, especially in light of his HIV, even though it's well controlled. The inflammatory markers are interesting. Those are very high. Obviously, there's a wide differential for elevated inflammatory markers. But a SED rate, an ESR greater than 100, you don't see very often. In the rheumatologic world, there's not a lot of things that cause a SED rate that high. Certain things that come to mind are like vasculitis, the crystalline arthropathies can do it. Some of our other inflammatory conditions can do it, but with this ESR that high, I also thinking of infection, malignancy, certainly. We see inflammatory we are always asking for inflammatory markers with the rheumatology consult. The sedimentation rate is more prone to kind of false positives. It goes up with age. Women tend to have higher SED rates. If you're obese, you tend to have a higher SED rate, but not too much will falsely push it into that high of a range. I think the other thing to note is that one thing I've found helpful to note is that sed rate will elevate and take a long time for it to come down. So if was an infection a week or two ago, it wouldn't be surprising that has resolved in a patient. It wouldn't be surprising for a sed rate to still be elevated. CRP has a much more rapid rise and fall. So if I can essentially know with that high of CRP that something is happening right now, which I wouldn't need the CRP to tell me that, but it's something I think about with the inflammatory markers. You know, given the white count and the inflammatory markers, I think the first thing I would ask for, even before any other labs, if this guy came through the emergency room, would be for someone to try to aspirate a joint to rule out a septic arthritis, because those markers, the fever, the white count, I would want to make sure I'm ruling that out really quickly, because if that's left untreated, it could lead to destruction of the joint. Were they able to aspirate anything?
Yeah, good question. Yeah, I completely agree. The ASR CRP are quite elevated, and thinking along the same lines, the team in the ED actually did joint aspiration, and they were able to aspirate a little bit of synovial fluid, and the analysis that we gained from that was that it was pale yellow, it was turbid, 14,000 white blood cells, gram stain was negative, and it was negative for crystals as well. So that's the synovial fluid analysis we have.
Okay.
So, do you want me to jump in here and just talk a little bit about how we look at that?
Please go ahead. I'd love to learn
Okay.
from you.
So first thing is, if there is fluid in a joint, we want it. Like, we want to look at it, we want to analyze it, we want to look for crystals, we want to look for an infection. So if there's a board question or something and there's fluid and one of the options is aspirate the joint, that is the answer. We want to know what's going on, and that tells us the most information, you know, acutely, especially with a hot joint, what's going on inside. So, you know, when we send it off, we're looking for a lot of things. The first thing is probably the cell count, right? So the white blood cell count. And normal, you know, it's normal to have synovial fluid. It lubricates the joints, but having large effusions and stuff is not normal. So when you get the fluid out, sometimes you can see actual frank pus if it's a septic joint. But so the color can tell you a little bit, but you can be tricked. So you always send it for the cell count. White counts, you know, below 200 are normal cells. That's the normal amount of cells that are in your synovial fluid. We also think about, you know, non-inflammatory arthritis, like I mentioned, some osteoarthritis and some other non-inflammatory conditions. You still can get fluid accumulating, and there can be white blood cells in that too. But it's usually still under like 2,000. You know, so it's like 200 to 2,000. I usually think about the twos. So up to 200 is totally normal. 200 to 2,000 is sort of this non-inflammatory type of fluid, but it's still there. And then once you're getting above like 2,000, especially when you're talking about what you mentioned, 14,000, right? You're definitely in the inflammatory range, you know? So you're thinking about things like crystal arthritis, you know, rheumatoid arthritis, psoriatic arthritis, reactive arthritis, septic arthritis. And when there's any concerns for septic arthritis, which even if someone has a history of RA or whatever it is, you're always still needing to rule that out. Like, as Josh mentioned, missing that is a big problem. And so, you know, we always, if there's any suspicion for a septic joint, we always send the fluid for culture. We're never going to just put steroids right into a joint if there's really concern for infection. So, you know, so oftentimes in the clinic, we'll aspirate and inject in clinic. We won't do that on the hospital wards unless we're really pretty certain there's no infectious process going on. And then the other thing we look for is crystals. So are there monosodium urate crystals in the fluid that are consistent with a gout type of process, or CPPD crystals going along with pseudo gout? So we're always taking the fluid to the microscope, you know, in our pockets and looking under to see if there's any crystals. And then the last thing that takes longer to come back is obviously the gram stain and the culture to see if there's any sort of infectious process going on. So the synovial fluid can be very helpful. And I think in this case, it sounds like clearly an inflammatory process. You know, reassuringly, the gram stain was negative and cultures were negative, but you always want to wonder, you know, was this person already on antibiotics? Were they treated for anything? And is it really positive? But at least that was negative. And then I think there was no crystals. So that also makes you think less likely that this is some sort of acute gout or pseudo gout type of flare.
Incredible. Thank you so much. Dr. Anisha, we actually have 2 questions from the chat.
Yeah.
So Sonia says, I've been taught that excluding MAS, autoimmune disease rarely has a CRP greater than 100. Do you find this to be the case, and does the level guide your differential diagnosis in any other ways?
Oh, a CRP greater than 100. Yeah.
Yes.
That, like Josh was mentioning, so SED rates and CRPs like that high really are big red flags. A lot of our autoimmune processes, like connective tissue diseases, will have, low grade fevers, elevated SED rates, some mildly elevated C-reactive protein. But once you're getting something that high, you're really thinking about infections, malignancies. Sometimes vasculitis can cause a CRP to be that high, but MAS would be one of the few things that could drive it up really high. Very heavy duty systemic inflammation. We think about giant cell arteritis with elevated SED rates. That's, again, in the vasculitis family. But things like lupus, scleroderma, rheumatoid arthritis, even when people are having flares, usually you're not going to see like high fevers and high inflammatory markers like that.
Incredible. Thank you. We also have one more question. It's Sammy. Yeah. How high would you expect the leukocyte count to be in a flare of osteoarthritis?
How high would you expect the leukocyte count to be in what?
In the flare of osteoarthritis.
Of osteoarthritis?
Yes.
So it can be normal, but it can still have some increased white cells. So I would say it would be less than 2,000, it would be in that non-inflammatory range. If it's starting to get higher than that, then you are thinking, is there any sort of concomitant inflammatory process going on? But sometimes these things can be tricky, and people don't always tell you that they've been treated with antibiotics or that they've been treated with prednisone for their asthma flare, and that can change your synovial fluid. So all of those things can kind of impact your analysis. But it's just sort of a general guide. If you're seeing something where there's more than 2,000 white blood cells, you just have to start thinking, is this like an oligoarthritis that might be pointing towards a seronegative spondyloarthritis? Or is this, is it really high? And I think the things that make you think about a white count in your synovial fluid more than 50,000 is really infection and crystalline arthropathies. Those are the ones that are really going to drive up your white counts in the synovial fluid.
Incredible. Thank you so much. Josh, what would you do now for this patient, like next steps?
Yeah, so I think in the setting, even though the gram stain is negative, I still have infection on my differential. I think in a couple of buckets. So, septic arthritis, as someone had mentioned in the chat, was spot on. It is usually monoarticular. So this would be a slightly unusual presentation, kind of the polyarthritis, an unusual presentation of septic arthritis. But it's definitely something I have on my differential. So I want to make sure to get blood cultures, certainly. The bugs that can cause septic joints, we usually think of staph, strep, gonococcal disease can cause it. The other thing for this guy, it looks like he has some swelling over the tendon. So I think about tenosynovitis. Infectious tenosynovitis is kind of exists along a spectrum with septic arthritis. But it can have a slightly different causes. So I think about kind of direct trauma from a fall. You can have a polymicrobial infection. You can have spread from locally infected tissue. Lakshmi didn't mention it, but if this guy had a dog or a cat and had a bite, that can often lead to kind of a staph or strep skin flora tenosynovitis. I think Pasteurella is also implicated in that. Gonococcal disease certainly can cause infectious tenosynovitis. So I'd want to make sure to get a check for gonorrhea. There are other unusual infections certainly that can cause tenosynovitis that I would think about, especially in a patient with HIV, things like tuberculosis. I'd want to investigate for. In terms of, there are many other infections that can cause arthritis. Certainly there are several viruses that can do it. So parvovirus classically causes kind of like a seronegative RA type picture, but can present diffusely. So I'd send parvovirus, or it can present in many different ways. I'd send parvovirus serologies, because an IgM that is positive can be very helpful in making that diagnosis. HIV in and of itself can be associated with arthritis. So there's a couple of conditions. One is something called HIV-associated arthritis. Again, it can present as kind of a non-destructive rheumatoid-like arthritis. Somewhat atypical for this guy, but I would want to make sure that he's got well-controlled HIV. Folks with HIV can also present with something called painful articular syndrome, which is a very unusual syndrome where they will develop excruciating painful joints for about 24 hours, and then it resolves without intervention. Doesn't sound like that's what's going on, but certainly think of that. Other infections, I think hepatitis B and C, we always think about, especially in acute to subacute arthritis. Fevers, are things we think about. So I'd want to get the test to rule those out. And then, someone also mentioned in the chat, but I think reactive arthritis is something to consider. So, reactive arthritis classically occurs 3-4 weeks after a GI or GU infection. This guy didn't note that, but it's possible it went, that he had a subclinical infection. Reactive arthritis can present with polyarthritis. Usually it's an oligoarthritis of the larger joints like this guy has. I can present with enthesitis, so inflammation of the insertion points, the tendons like he has. Someone also brought up in the chat that indeed that you cannot recover organisms from the synovial fluid. So a negative tap doesn't rule out reactive arthritis. But it's something else that's on my differential. So I'd probably start there. So I'd get kind of gonococcal studies, parvovirus. I'd want to make sure to get an HIV viral load just to make sure we are dealing with well-controlled HIV and hepatitis studies.
Terrible. Thank you, Josh. Anisha, would you like to add something?
No, I think Josh did a good job of sort of discussing what the differential would be from here. There's infection that's truly in the joint, and then there's a lot of infectious processes that can cause inflammation in the joints where you're not going to have actual true, gram stains or cultures that are showing something up. So, we always, like I said, rule out the most dangerous stuff first. So septic arthritis, infection, and then we start looking for some of the other clues that might point us in a different direction. I think, reactive arthritis, hepatitis, all of these are still infectious processes that can make people have, confusion, low-grade fevers, elevated inflammatory markers, and the joint fluid, could be consistent. There's nothing coming up. I think I would look farther along the lines. I think the questions that Josh is asking for lab-wise make total sense. Of course, if he's had this persistent stuff, I think imaging findings might be helpful as well. Sometimes, depending on what type of imaging you find, it can give you some clues. X-rays are not great for really evaluating the joints in some ways. I mean, they're good with long-standing processes, or they're good for trauma. They can tell you if a joint is broken. They can tell you if there's been sort of long-standing inflammation, but it takes a few years between, like, for example, the onset of RA and actually seeing erosions in the joints. You can see some early signs of periarticular inflammation and stuff on X-rays, but you can get much more detailed information from things like an MRI or ultrasound or something like that. So I would be open to getting some sort of joint imaging as well.
Well, thank you so much, Dr. Anisha. We can go ahead, Dr. Lakshmi.
Okay. All right. Josh, excellent questions once again. So the patient does have a dog. I look back and the patient does have a dog, but no recent bites. They've documented that. Does not have any other pets at home. We do have some of the infectious workup that you had mentioned. So they did check a urine gonorrhea study, like a urine nat that was negative for gonorrhea. They checked a quantiferon gold that was negative, parvo IgM negative, hep B, hep C negative. And like I mentioned earlier, his HIV is well controlled, regular on medicines, and his CD4 was 414. And I think those are the main studies that you mentioned. And I know that you and Dr. Dua had asked about imaging as well. So we do have imaging of his wrists and his shoulder. And just on a side note, they are working up his confusion to all the viewers there, and his MRI brain was normal. His LP was also not suggestive of a CNS infection. So that aside, his MRI of his wrists did show soft tissue edema with features of extensor compartment tenosynovitis on the left side. And then on the right side, it mainly showed some ulnar flexor bursitis. So tenosynovitis on the left and bursitis on the right side. And he had a right shoulder MRI as well, which showed that there was active synovitis in the glenohumeral joint on the right shoulder. Other than that, his brain MRIs we covered as well. That was negative. So at this point, what are you thinking, Josh? This is pretty much the data that I have for this patient.
Yeah. So, we have a 58-year-old guy with well-controlled HIV. He presenting with a week of joint pain and confusion, found to have synovitis and really tenosynovitis, and with elevated inflammatory markers and a fever and an elevated white count. I think it's hard. It's quite hard not to think about infection still. And someone brought it up in the chat, but he's had a urine gonorrhea done. Do we need to do a rectal and pharyngeal swab for gonorrhea? Do we need to go back and ask him anything more about the history? Do we need to do a more thorough skin exam? I think oftentimes what happens with these patients where the initial workup is unrevealing, they get started on broad spectrum antibiotics, and they start to improve if it's an infection, and then we never quite know what's going on. I'm kind of curious what the primary team did with him.
Yeah.
Maybe Dr. Dua, since this is the last aliquot, can you give us your input as well, please?
Sorry, since it's what?
I think it's the last aliquot. Isn't
yeah.
right? Yeah.
I think Lakshmi will tell us, I think, a little bit more about the case, but yeah. And there were a couple questions, I think, in the chat, about sort of like serologies and other stuff. So I think this is just an important teaching point. I know not to get away from the case, but when there's a patient who's being seen by rheumatology, there's like people have this tendency to order what they call like a Rheum panel. And I'm like, just want to make it really clear that that is not a thing. So we don't want to just go arbitrarily ordering like every serology on every patient, because there are so many, and it really leads to a lot of costs on like downstream confusion. Patients end up with this positive random blood test that they don't know what to do with. And then they have to follow up, they have to get all these extra studies. And so you really want to order tests based on your clinical suspicion for a disease state, right? Because it's just, otherwise it'll drive your patients crazy, you crazy, and we don't have much to offer them with just a positive blood test. And the serologies can be very confusing, but how many people come in when we're like, I don't really understand why the ANA was ordered, and then we have to just sort of reassure them and watch them and tell them, it can be tough. So that being said, with this patient with this, what Josh had sort of did a nice recap of, this inflammatory process with a sort of oligoarticular polyarthritis, it doesn't mean that they can't have RA or anything like that. And I wouldn't be surprised if those labs were sent off, an ANA and a rheumatoid factor and a CCP and everything else, because they tend to just be sent off a little bit reflexively. But again, you don't want to check an ANCA in everyone. You don't want to check an ANA in everyone. You want to think about what are these clinical features that are making you think that this could be the diagnosis, and then using that blood test to confirm or not confirm, your diagnosis, or help like push you in one direction or another. So that's a side note, but what was your question again? I just wanted to make sure that point
No, that was incredible. I actually asked you about your input, and I loved your appeal about like being very systematic on what you choose to order for the patients, because I experienced that as well, like patients with positive ANA, and you're like, oh my God, what do I do with this?
No, of course. And there are more specific tests, but the ANA, again, teaching point wise, 1 out of 5 people can have a positive ANA and they have no underlying autoimmune disease or inflammatory like arthritis going on, but it's stressful, like you don't know what this positive blood test is about, and there are false positives. But I do think, again, like Josh said, with this type of presentation, where you've got a lot of negative blood tests. We've done a pretty good workup for infectious causes. There's still some sort of inflammatory process. I think you are wondering about like a reactive type of arthritis. And I think at this point, you kind of go back to the patient and you start sort of digging a little bit deeper. Sometimes we do the workup and we hope to get an answer, but is this patient being covered with antibiotics? Could anything else be sort of driving this process? Did we not do all the tests that needed to be done? So I would probably loop back to the patient and see what we're missing.
Thank you. So Lakshmi, could you tell us what happened to this patient?
Of course. So echoing the same thoughts that Dr. Dua and Josh mentioned just now, the team was also perplexed by this case. Due to high suspicion for still a septic process going on, they did cover him with broad spectrum antibiotics. They felt his risk factors for having possibly a septic joint were the fact that he already is immunocompromised. He's an HIV patient. He has chronic illness, he has diabetes, he has HIV. So those are all risk factors. The age population, you do tend to look at like elderly patients and children to be highest at risk, but not to exclude the ages in between. If you do have chronic comorbidities such as alcoholism, diabetes, HIV, that puts you at risk. And also if you're on immunosuppressive agents or you have a condition which affects your immune system. So with all those risk factors, they still had high suspicion for an ongoing infection, and they covered him with broad spectrum antibiotics. And like we're all taught in med school and throughout our training, you get a lot from the history of the patient. And many times you can even come to a diagnosis just based off of the history and the story that the patient is telling you. So the team went back to the patient to ask further about any kinds of stigmata of infection, any other risk factors. And they found out that in fact that he was engaging in sexual activity with multiple partners. And this again raised their suspicion for a sexually transmitted disease and wanted to pursue a more thorough workup. And they got a rectal swab, which was positive for chlamydia and negative for gonorrhea. And they got a throat swab, which was actually positive for Neisseria gonorrhoeae. So the final diagnosis from the team was a disseminated gonococcal infection, which caused the patient to present in the manner that he did. But yeah, excellent dissection by Josh and Dr. Dua, of course, and wonderful questions by the team. And if you'd like, I can go ahead and give a short, Josh can give a short discussion about disseminated gonococcal infection, just clinically what to look out for. Is that okay? Is there anything else, Rafa, that we should do?
No. Yeah, please go ahead, Josh.
Okay.
Sure. So disseminate. Oh, Lakshmi, did you want to?
Yeah, I can go ahead and start and then
sure.
just jump in wherever you have any additional information, which I'm sure you'll have. So disseminated gonococcal infection is basically bacteremic spread of Neisseria gonorrhoeae. That's just to start with. And then how I think about it is just dividing it mainly into two syndromes. So one syndrome is where you have purulent arthritis and like a proper septic presentation. The other is a triad. It's the triad which we would have learned when we're preparing for exams and everything. It's the triad of tenosynovitis, dermatitis, and migratory polyarthralgias. So when you're thinking about tenosynovitis, the pain is out of proportion to what you would expect. You just palpate even lightly and they'll be exquisitely tender. One way to differentiate, okay, is it coming from the joint or is it coming from the tendon, is if you palpate, examine the joint, but in addition to that, if you palpate along the tendon. And typically in these patients, the pain will be similar, even if it's in the joint and even along the tendon, and it'll be exquisitely tender, quite severe pain. Typical joints that are involved are wrists, fingers, and toes for the tenosynovitis. Dermatitis, so skin findings, that's why Josh was alluding to, like, does he have any like trauma abrasions was related to the fall, but he was also asking if he has any rashes. It's because you can find pustular lesions in the extremities in patients with Neisseria gonorrhoeae, and 2/3 of the patients with disseminated gonococcal infection can have these lesions. So it's quite common. Important to do an extensive skin exam. The polyarthralgias, they can be migratory. Most common joint affected is the knee. Then in addition to that, you can get wrists, ankles, elbows involved. And then in addition to that, you can have constitutional symptoms like fevers, chills, malaise. And interestingly, only 25% of the patients with disseminated gonococcal infection have genitourinary symptoms. So I know Josh straight off the bat asked, okay, any penile discharge or anything, but he asked that keeping in mind that only 1/4 of the patients actually have genitourinary symptoms in these cases. So it's not enough to say doesn't have any GU symptoms, doesn't seem like gonococcal infection in these cases. Risk factors. So the other important part you want to keep in mind is what's your population that's predisposed to get a disseminated gonococcal infection. So typically young patients, young healthy patients less than 40, sexually active with multiple partners, women peripartum phase, women around their menstrual cycles, they're all predisposed. And then if you find these clinical features to tag along with it, that should raise your suspicion for a disseminated gonococcal infection. And surprisingly, the most common cause for septic arthritis less than the age of 30 historically was disseminated gonococcal infection. And that, of course, the incidence has reduced now because we have great ways to detect and treat it. But this was historically the most common cause for septic arthritis in a young, healthy person. Workup wise, so you do your basic workup just like we did, your CBC, CMP, you can check your inflammatory markers, you can check blood cultures. Cultures in this case, they're more helpful when they're positive, but negative doesn't really rule it out. Important part, like what Josh alluded to, was that we need swabs of all mucosal surfaces. So rectal, skin, pharyngeal, urethral, cervical, all. So this patient actually started out with just a urine sample, but a negative urine sample alone is not sufficient to rule out a disseminated gonococcal infection. It's important to swab all mucosal surfaces, as we learned from this case. And then briefly about treatment. Historically, we've gone through penicillins and a variety of other antibiotics, but right now the mainstay of treatment for disseminated gonococcal infection, according to the CDC 2021 guidelines, is ceftriaxone, which is alarming or like scary in a way, because as antibiotic resistance increases, we'll be out of our arsenal to treat this infection, which is why another point is to make sure you're using your antibiotics judiciously. But as of now, maintenance, the treatment is mainly ceftriaxone, 1 gram IV, and that's the main treatment for disseminated gonococcal infection. But that's mainly, Josh, do you have anything else to add?
No, I think that was a great summary. And yeah, I mean, our infectious disease colleagues, when we share these patients, they'll let us know that ceftriaxone is the only thing that covers disseminated gonococcal infection now. And there are some parts of the world where resistance rates to ceftriaxone are creeping up into the 4 or 5%. So there really is a risk of gonococcal infection and disseminated gonococcal infection becoming untreatable, unfortunately. So I think this is definitely, it's something that all medicine people need to be aware of, because the rates are going up, certainly.
So firstly, Lakshmi, excellent breakdown of the case. Thank you very much for all the teaching points. Thank you, Josh. And before we finish the session, Dr. Anisha, when you see this case, what do you think that learners should take away from this? The main teaching points for you?
I mean, I think, we touched on a lot of important topics, but I think really when you're thinking about somebody with joint pain, there's so much more to joint pain than just joint pain. And so figuring out what, how to like make your differential, incorporating all the different blood tests, incorporating the physical exam findings, ordering the appropriate tests. And then of course, I think one of the biggest points is going back to the patient and really getting the story, and making sure that you're not missing things. Because with all these patients, especially complex rheumatologic patients that we see in the hospital, they have so much history coming in. And I just think it's really, really important not to jump to diagnoses and start treatment, or, I think you gotta work all this up. And it's hard when you see a patient not to just try to treat, and get something under control, but really sort of pausing and going back to the story and making sure you're really considering all the options. And if you miss something, like we forgot to swab the throat and the rectum, and when you go back and think about it again, you can pick up those important things and treat the patient appropriately. So no, I think this is a great case. I'm a vasculitis person, so I usually always want to bring like vasculitis cases to the table. But Josh and Lakshmi were great and took care of this patient. And so I think it was a really good discussion.
Yeah, it was excellent. Thank you so much. Just lastly, I would like to add that don't order any if you're not thinking about certain types of disease. Another teaching point that you mentioned that's so brilliant. So to finish the session, Chiara, could you do the teaching points, please?
Yes, of course. This was a beautiful case, very important topic. Thank you so much for presenting. So first, I think the most important why to choose rheumatology. We received many, many, many great information about that. So we know that if you choose rheumatology, you can connect all the dots, which is amazing. Is the best part of the medicine. Also, patients are amazing, and every day is a challenge. So if you're unsure where to go, you can choose rheumatology because of this. So we start with a very amazing chief complaint, which is joint pain. So we receive a very detailed and very detailed about how to proceed when we have a joint pain. So we have to think about many things. First, if this is an active or passive limited range of motion, because this can give us some clues. Then we have to think about if this is monoarticular or oligoarticular or polyarticular joint pain. Also, we have to think about clues if this can be an inflammatory versus a non-inflammatory disease. For example, inflammatory, our amazing clue could be more in stiffness that could lead us to think about rheumatoid arthritis, or non-inflammatory, which make us think about mechanical, like just are not non-inflammatory arthritis. I forgot the word. Then it's also important to see that pattern, like if this is migratory, localized, peripheral, or this can be a relapsing joint pain. And we also have to think about the red flags. If there are some abrasions, like make us think about septic arthritis, if there is rash, GI, or genitourinary symptoms, or fever, for example. Also, it is important to see if there are elevated inflammatory markers. We received an amazing class about inflammatory markers. For example, ESR and CRP can be elevated in women and in elderly. And if we have ESR or CRP more than 100, we have to think about infection or malignancy. And of course, some vasculitis like giant cell arteritis. We also learned that ESR takes more time to decrease than CRP. And very important is that if we have an increased fluid in the joint, please aspirate and check the color. The white blood count is very important. If it is less than 200, this is probably normal. If it is in the range between 200 and 2000, this is probably in the range of non-inflammatory disease. And if it is more than 2000, we can think about inflammatory disease like RA, psoriatic arthritis, rheumatoid arthritis, or the worst part, septic arthritis, like in this case. And what can we do if we are thinking about septic arthritis? Take gram and cultures. And don't forget about the crystals, because we can have a gout or pseudogout, and we can differentiate with the crystals, and of course the clinical. Then, as we had a patient with HIV, what do we think when we have HIV and tenosynovitis? And Dr. Josh told us that we can think about TB or HIV itself, because there are some HIV-associated arthritis, like non-destructive rheumatoid arthritis, or there is also a painful articular syndrome that is an excruciating painful joint that disappears in 24 hours. So in this case, we are thinking about septic arthritis. So what to do next? It is very important to cover with broad-spectrum antibiotics, especially because these patients have many risk factors to take in consideration. So also very, very important, and this is a great pearl that I will take everywhere, is that there is not a rheumatology panel. So don't do that, please, and order labs according to the clinical suspicion that we have. And also very important to go back and check what we have missed, because in this case, this patient had a very important risk factors of probably a sexually transmitted disease. So finally, we have a disseminated gonococcal infection, which was the final diagnosis, and we have a purely arthritis syndrome or a triad that we all know that is migratory polyarthralia, tenosynovitis, and dermatitis. And for this, it's very important to check very well the skin and perform a good clinical exam to determine if this is a tenosynovitis, as Dr. Lakshmi showed us. So amazing case. I love this case. I learned so much, and thank you for all of this.
Oh, thank you so much, everyone. Thank you, Lakshmi. Thank you, Josh. Thank you, Anisha. It was such a pleasure to have you here
Of
in Learning
course.
Stones. Thank you.
Thank you guys.
Thank you. Thank you so much.
Thanks a lot. Bye, everyone.